The broadcast is now starting. All attendees are in listen-only mode.
All right, Dr. Laban, it's all yours.
Thank you. I first wanted to welcome everybody to Northeast Regional Epilepsy Group webinar on women issues in epilepsy. This is a very broad topic, as you know, and I will try to summarize the most important points. As you know, epilepsy affects approximately 0.5 to 2% of the population, which is about 3 million people in the United States. It is very common. It is almost equally common in men and women. About 1.5 million women is living with epilepsy in the United States, and it's estimated that about 500,000 are women of childbearing age. Some types of epilepsy are more common in women. For example, generalized epilepsy, mostly due to the slightly higher frequency of juvenile absence epilepsy and juvenile myoclonic epilepsy syndrome. Also, cryptogenic partial epilepsy or partial epilepsy of uncertain origin is slightly more likely to occur in women, while symptomatic partial epilepsy or partial epilepsy of known origin is more common in males. However, men and women have similar risk for recurrent seizures and similar risk and likelihood of ultimate remission of epilepsy. The effect of epilepsy on women's life is a result of complicated interplay among epilepsy, female hormones, and anti-seizure medications that are used for treatment. And we are just starting to learn more about this interaction. The effect of endogenous female hormones is evident in catamenial epilepsy. It is believed that hormones change the excitability of the brain and alter the threshold for seizures. Estrogen may be enhancing excitability and decreasing seizure threshold, possibly due to reducing the inhibition and GABA-A receptor or inhibition of GABA synthesis. On the other hand, progesterone may be enhancing inhibition and increasing seizure threshold, making seizures less likely, possibly due to the increase in inhibition at GABA-A receptors, decrease in excitation of glutamate in hippocampus, or increase in GABA synthesis. Hormone-sensitive seizures are also known as catamenial epilepsy, which comes from Greek word catamenius, or monthly. It is defined as change in seizure pattern that corresponds to menstrual cycle. And about 30 to 50% of women will report this epileptic pattern. This may occur with any type of epilepsy or any type of seizures. There are some reports that it's more common in women with left temporal lobe epilepsy. Possible mechanisms are multiple. One of them is, as previously mentioned, shifts in estrogen and progesterone balance during menstrual periods. The other possible mechanisms are fluctuations in levels of anti-seizure medication. Some of them are due to the changes in the estrogen and progesterone balance, fluid and electrolyte imbalance, and psychological stress. We will focus here on the effect of shifts in estrogen and progesterone balance on the hormone-sensitive seizures. Since the estrogen is decreasing seizure threshold and progesterone is increasing seizure threshold, vulnerability to seizures should be higher at periods of relatively high estrogen and low progesterone. There are three patterns of catamenial epilepsy that were described. Pattern 2, or pre-ovulatory, is due to this steep elevation in estrogen levels just before the ovulation, approximately around day 14, which may result in an increasing frequency of seizures. Pattern 1 is known as perimenstrual, and is due to the steep decline in progesterone just before the menstrual period, so occurs in days preceding the menstrual period. Pattern 3 is especially important because anovulatory cycles are more frequent in women with epilepsy. In these anovulatory cycles, there is no release of egg, there is no ovulation, therefore there is no production of progesterone, and there is unopposed production of estrogen, which continues throughout the second half of the menstrual cycle. And because of that, some women during these menstrual cycles, which are anovulatory, may experience increasing frequency of seizures throughout the second half of the menstrual cycle. There are different strategies in managing catamenial epilepsy. Most common one is increasing dose of anti-seizure medications during that particular time of menstrual cycle. Sometimes other medications are added due to the time of expected increase in frequency of seizures. The other approach is the supplementation with reproductive hormones that will increase seizure threshold. For example, cyclic supplementation with progesterone, so 14 days without and 40 days with natural progesterone, may result in improvement in catamenial seizures. And in some women in which this is appropriate, suppression of menstrual cycle, for example, with Depo-Provera, can also help with the control of seizures. Treatment with acetazolamide is of limited benefit. The effect of epilepsy is also pronounced on the women's reproductive issues. And this is evident in the irregularities in menstrual cycle, infertility, decreased libido, and early menopause that are more frequent in women with epilepsy than in general population. Menstrual disorders are estimated to occur in 1 of 3 women with epilepsy compared to 1 in 7 in the general population. And 1/3 of menstrual cycles in women with generalized seizures are anovulatory. Polycystic ovary syndrome is twice as common in women with epilepsy. It occurs in 10 to 25% of women with epilepsy compared to 7% in general population. Polycystic ovary syndrome is defined as 2 of the 3 of following: multiple cysts in ovaries, so they're not necessary for diagnosis, high male hormone levels, and excessive facial hair and acne. Other features include irregular menstrual periods, more frequent anovulatory cycles, and obesity. Syndrome is twice as common in women with wet epilepsy, but it's more common in women with left temporal lobe epilepsy and left-sided EEG discharges, and was also described as being more common in idiopathic generalized epilepsy. Possible explanations are that the seizure activity in brain alters the production of female hormones via hypothalamic pituitary gonadal, or HPG axis. Also, there is some question that possibly valproic acid causes features similar to polycystic ovary syndrome, although not necessarily syndrome itself. Hypogonadotropic hypogonadism was also more common in women with right temporal lobe epilepsy and right-sided EEG discharges, which again suggested that the effect of epilepsy may be due to the alteration at the level of HPG axis. Women with epilepsy also have higher occurrence of sexual dysfunction. This is related to higher sexual dysfunction scores, lower mean arousal, and higher depression scores. Sexual dysfunction was more prevalent in women receiving enzyme-inducing anti-seizure medications than in control. Possible mechanisms are dysfunction of the frontal and temporal lobes due to seizures, or the effect of anti-seizure medications, either on the cortical function, like we know about the sedative effect, or effects on hormone binding and metabolism. For example, elevation in prolactin, which is common after generalized tonic-clonic seizures, and gonadotropin levels can suppress libido. And of course, we shouldn't underestimate the effect of psychological and social factors on the sexual disorders. Fertility or infertility is defined as no conception after 12 months of sexual activity without the use of contraception. In women with epilepsy, we also talk about the childbirth rate of live births. And women with epilepsy have lower frequency of live births compared to general population. So 47 in 1,000 compared to 62 in 1,000 women without epilepsy. Again, the possible explanations are numerous. One is choice. The other is sexual dysfunction and higher frequency of menstrual disorders, as we already discussed. 1/3 of women with epilepsy reported they do not consider having children because of epilepsy. And also it was reported that women with epilepsy are less likely to marry, although it doesn't seem that its fertility deficit persists when analysis is restricted to married women only. The childbirth rate was lower in women who had early age onset of epilepsy and in women with localization-related epilepsy. In one of the studies, it was also shown that there is association with a number of the anti-seizure medications and the anti-seizure medication exposure with the birth rate. And the lowest childbirth deficit was noticed in the women who had no anti-seizure medication exposure but had epilepsy, while the more anti-seizure medications were used, the lower the number of children was reported. Now we will talk a little bit more about the exogenous hormones and epilepsy. Some of the anti-seizure medications may decrease efficacy of birth control pills and other hormonal birth control, which may result in birth control failure and unplanned pregnancy. And there are estimates that even over 50% of women with epilepsy may have unplanned pregnancy. Possible mechanisms of interactions between anti-seizure medications and hormonal contraception are through the induction of P4 persistence and through the induction of production of sex hormones binding globulin, which will result in decreasing the levels of the free hormone. Anti-seizure medications that may decrease efficacy of birth control are carbamazepine, phenobarbital, phenytoin, primidone, rufinamide, clobazam, and at higher doses, topiramate and oxcarbazepine. This is a very important issue to discuss with women when these medications are started. These anti-seizure medications seem to have no influence on levels of steroids, and medications such as valproate and salbutamol may actually increase the levels of some of the sex hormones. The best solution in avoiding the failure of the hormonal birth control is to use anti-seizure medications that do not interact with birth control pills, or to use alternative birth control methods. Controversial solution to this problem is to use birth control with higher doses of estrogen or more frequent depo-provera shots. And if there is a breakthrough bleeding, to increase dose of estrogen or add barrier methods. But however, pitfalls of this approach is that there is no proof that higher dose of estrogen is sufficient to prevent pregnancy, and absence of breakthrough bleeding is not proof of efficacy. Intrauterine devices can also be used, like copper IUDs or hormone releasing, and since the effect is based on local influence of hormones on the endometrium, it is unlikely to be affected by the anti-seizure medication. On the other hand, the estrogen component of birth control pills and hormone replacement therapy can significantly decrease levels of lamotrigine, therefore resulting in breakthrough seizures. This is the effect of the hormones on lamotrigine is very pronounced during pregnancy also. The possible mechanism is through the effect on the glucuronidation, and therefore the other anti-seizure medications such as valproate and oxcarbazepine, which are metabolized in a similar way, may be affected. We will now focus on the effect of epilepsy on the different reproductive life stages in women's life. And we will start with pregnancy. One thing that we point out to women with epilepsy is that over 90% of babies born to women with epilepsy will be healthy. And that this number may be even higher if all the pregnancies were planned. Although low, birth defect rate is still about twice of rate in general population, somewhere between 4 and 7% compared to 1.6 and 3.2%. Most common major congenital malformations are neural tube defects, heart abnormalities, and orofacial collapse. There is a higher risk for this major birth defect in women who had breakthrough seizures or on anti-seizure medications and also have genetic predisposition. As for seizures in pregnancy, seizure freedom for at least 9 months prior to pregnancy is probably associated with high likelihood of remaining seizure-free during pregnancy. So achieving seizure control before pregnancy is extremely important. Also, it was described that women with catamenial epilepsy have lower risk of seizure during pregnancy. On the other hand, women with localization-related epilepsy, on polytherapy, and who had seizures in pre-pregnancy months are more likely to relapse during the pregnancy. What are the risks of seizure during pregnancy? One is fatal risks of intracranial hemorrhage, suppression of fetal heart rate, and miscarriages were described. As for maternal risk, trauma is leading cause of non-obstetrical cause of death in pregnant women, and also higher death rates was described in women with epilepsy. Major malformation rates are higher in women who are on polypharmacy, 2 or more anti-seizure medications, and who are on higher level of anti-seizure medications. For example, major malformation abnormalities major congenital abnormalities were described in 4.5% of women on one anti-seizure medication, but 8.6% in women with polytherapy. We, of course, know that not all anti-seizure medications are the same, and valproate stands out with significantly increased the risk of malformations compared to the other anti-seizure medications. Also, some of the late effects of valproate were described. For example, children who were exposed to in utero valproate, in those over 800 milligrams, had lower IQ at 6 years of age, had lower early cognitive development, and had increased rate of autistic spectrum disorder. As for children exposed to in utero carbamazepine, there was no change in the IQ, but one of the subsets of IQ, verbal ability, was reduced at 6 years of age. There was no trend for any abnormalities in the children who were exposed to in utero lamotrigine. So what can be done about anti-seizure medications? It is very patient-specific. We are trying to reduce medications to single medication in patients who are in polytherapy. We're trying to change medication to those that are less teratogenic. We're trying to decrease those medications to the minimum necessary to control seizures. And in rare cases, depending on epilepsy syndrome and seizure frequency, we are sometimes attempting to stop medication before pregnancy. This, of course, has to be done way in advance in order to allow enough time to see whether the seizure control is adequate. AAN guidelines suggest that it is highly probable that the intrauterine first trimester valproate exposure has high risk of major congenital malformations compared to carbamazepine, phenytoin, and lamotrigine. Probable that valproate as part of polytherapy and possibly as monotherapy contributes to the development of major congenital malformations, and that anti-seizure medication polytherapy probably contributes to the development of major congenital malformations. If the single anti-seizure medication does not control seizures, it is considered better to be on 2 anti-seizure medications than to have seizures. Folic deficiency is associated with increased risk of neural tube defects, and anti-seizure medications that have linked to folic acid malabsorption and metabolism are phenytoin, carbamazepine, barbiturates, and valproate. However, there is no evidence that folic acid specifically reduces the risk of teratogenicity due to the anti-seizure medications. And data addressing folic acid dosing is insufficient. So it is recommended that all women of childbearing potential should be supplemented with at least 0.4 milligrams of folic acid before conception and during pregnancy. What do we tell patients? Most important, to plan pregnancy. it is extremely important to achieve good seizure control before pregnancy, that we may have to change anti-seizure medications and dosage, to start folic acid way before pregnancy, to start prenatal vitamins, to establish good relationship with their neurologist or epileptologist, as they will require close supervision throughout the pregnancy. And we frequently suggest that they be evaluated with high-risk pregnancy OB in addition to their obstetrician. We also discuss possibility of genetic counseling, especially if there is a history of birth defects in family. And then once they're pregnant, we instruct them not to stop their medication, to consider prenatal testing, to continue folic acid and prenatal vitamins, and to continue their close follow-up with neurologists, epileptologists, and OB. And for prenatal testing, we discussed the maternal serum alpha-fetoprotein at 15 to 20 weeks of gestation, structural ultrasound at 16 to 20 weeks, and amniocentesis at 15 to 20 weeks of pregnancy. Frequently get asked why do prenatal testing. Well, some birth defects require special attention during pregnancy or during delivery, and some birth defects may require surgery immediately after delivery or even before delivery to improve the outcome. So it's important to know. Then we also discussed very closely that the levels of their anti-seizure medications may be significantly increased during pregnancy, and that is in order to maintain the level of the medications in their body stable and avoid possible breakthrough seizures. Also, after delivery, the doses of medication will need to be decreased in order to avoid toxicity. Levels of anti-seizure medications drop in second trimester due to increase in drug clearance, increase in maternal plasma volume, and decreased protein binding. Therefore, frequent testing and adjustment in dose of medication is absolutely necessary. This is somewhat controversial topic. Anti-epileptic drugs compete with vitamin K across the placenta, and those that do so are carbamazepine, barbiturates, and phenytoin. We usually defer this to OB, and we ask women to discuss need for vitamin K supplementation in last month of pregnancy with them. Hospital delivery should be encouraged with women with epilepsy. And it has been shown that women with epilepsy who are taking anti-epileptic drugs have possibly a moderately increased risk of C-section delivery. They probably have no substantially increased risk of late pregnancy bleeding, and probably no moderately increased risk of premature contraction or premature labor. However, they have possibly a substantially increased risk of premature contractions and premature labor and delivery if they're on anti-seizure medications and they smoke. Recently, there was a study that was somewhat concerning, in which it was reported that the risk for death during the delivery hospitalization is almost 10 times higher than in women without epilepsy. The data in this study is somewhat difficult to interpret because these women were identified by the ICD-9 code, and we do not have the details about their types of epilepsy medications, comorbidities based on this study, but it's definitely something that is concerning. This study also reported somewhat heightened risk for preeclampsia, preterm labor, stillbirth, and also increased risk for C-section delivery. The other thing that we point out to our women early on is that breastfeeding is not contraindicated. On contrary, benefits of breastfeeding are thought to outweigh potential risks of continued exposure of neonatal infants to anti-epileptic drugs. But the babies need to be observed for irritability, for poor sleep patterns, or inadequate weight gain. And we also discussed with them that some protein-bound drugs have lower concentration in breast milk, such as well-pressed phenobarbital, phenytoin, and carbamazepine, compared to some of the newer anti-seizure medications such as levetiracetam, lamotrigine, gabapentin, and topiramate. We also discussed that the anti-seizure medication levels will rise, and that close monitoring of levels is still necessary, and the doses of anti-seizure medications may need to be decreased. It has to be very well balanced with their sleep deprivation and stress that may contribute to seizures. We also discussed in detail the child safety and lifestyle adaptation that are necessary. As for puberty, education of girls in adolescence is extremely important. Most seizure disorders are not altered by onset of puberty, but certain types of epilepsy start at this approximate age, like juvenile myoclonic epilepsy, or improve, like benign epileptic epilepsy and abscess epilepsy. And sometimes rapid growth may account for poor seizure control. We discussed very carefully choice of medications, substance abuse in epilepsy, effect of sleep deprivation in epilepsy, compliance to medication, which is very, very difficult to maintain at this age. Then we discussed driving and specific driving laws for each state, sport safety, and we also tried to discuss with them their choice of profession so that they, depending on their prognosis, depending on epilepsy syndrome and their interests, they can choose the profession that will be least affected by epilepsy. At the time of the first menstrual period, we discussed catamenial epilepsy, interactions of anti-seizure medications and birth control. We start folic acid supplementation, and we also discussed planning of pregnancy. Some side effects of anti-seizure medications are very important to consider in this population. For example, weight gain, coarsening of facial features, hirsutism, hair loss is going to significantly decrease the compliance to medication if they're aware of them. And therefore, the choice of anti-seizure medication has to be made in agreement with the woman. Now we will switch to menopause and perimenopause. So in perimenopause, the hormone levels are somewhat erratic, as this slide shows. And then in menopause, the levels of estrogen and progesterone are at low levels. Premature menopause is more common in women with epilepsy than in general population. So about 14% women with epilepsy have premature menopause that occurred on average 3 years earlier. And this correlated with lifetime number of seizures and was not influenced by the anti-seizure medication. Effects on seizure frequency is unclear since both estrogen and progesterone levels drop, but catamenial epilepsy seems to improve in menopause. In menopause, we also have to adjust anti-seizure medications due to changes in metabolism. We try to avoid polypharmacy, and we also discuss bone health and hormone replacement therapy. Hormone replacement therapy may increase seizure frequency, and sometimes the use of natural progesterone may help with that. On the other hand, some of the anti-seizure medications may affect the efficacy of the hormone replacement therapy. We also discussed before the menopause, the bone health, because fractures are more likely in people with epilepsy due to falls and due to the altered bone density, and this affects both men and women. Anti-epileptic drugs that are associated with bone loss are phenobarbital, primidone, phenytoin, carbamazepine, and valproic acid. So anybody who is on this therapy for more than 6 months or even earlier is usually educated about the significance of exercise, balanced diet, cessation of smoking, moderate alcohol and caffeine intake. We usually suggest calcium and vitamin D supplements, which check yearly calcium, alkalos, and vitamin D. And we also obtain baseline bone density scan, and then we repeat it periodically. In case that there is some abnormality noticed on this test, they usually refer to endocrinologists for treatment, and we consider tapering off the anti-seizure medications that may increase their risk if that is possible. So thank you very much for attending this webinar. And if you have any questions, please email them to Tijan at the email that was provided earlier in the talk. Thank you.